Hi, I am Dr. Ajay Thakur, sports specialist. When I first saw her, Vaishnavi was almost on the verge of a major depression. She had been doctor shopping and had visited many orthopedic surgeons and physios. She had been having this knee pain, and all sorts of investigations were done, including a cardiogram and a PET scan. Somebody even advised her a diagnostic arthroscopy of the knee. Going through all the reports, I knew there was something they have all missed. Because Vaishnavi was a 14-year-old tennis player, and then she had been practicing since she was 8 years old. Now imagine her playing for almost 6 years, practicing every day, 6 days in a week. So she had now developed anterior knee pain, and which has been bothering her from the past few months, and so much so that she was not able to play sports also, her tennis. There can be many causes of knee pain. You see, it can be a quadriceps tear, it can be Chondromalacia of the patella, it can also be patella tendinitis, and for our age group it can be Osgood-Schindler's disease or a medial plica. But most commonly we would think of a overload, workload which was there from the past 6 years has accumulated and then causing some problems in the knee. I started with the examination, and then what I found was that her patella had some tenderness, and then there was some minimal effusion. I could not find a ligament tear or a meniscus tear, and then I looked at the alignment. There was no malalignment like genu valgum or varus, and then she did not have a flat foot or a high arch foot. She had even received 2 PRP injections in the knee, and she had a very short duration relief with that. Now, then I proceeded to examine her hip joint. So I did the basic test, and what I found was that her hip had a very weak abduction. So her gluteus medius was weak. We came to know when we did the Trendelenburg test, it was positive. So when we asked her to stand on the leg, the other side hip dipped down, saying that the hip abductor was weak. And then other examination also showed that she had a tight adductors and internal rotator muscles. Now, we always confirm our clinical examination. So I took her to the lab, and I did the biomechanical gait analysis, and that confirmed that she did have some increased hip adduction at toe off, and also there was decreased activation of the gluteus medius muscle at the toe off. Once it was confirmed, I called in my physio, and then I discussed the whole scenario with him, and then we started working on stretching her adductors and internal rotators of the hip, and then we started strengthening her hip abductors, and we worked on her core muscles, and by the end of 12 weeks, her biomechanics of the hip joint and the leg improved, the knee valgus angle decreased, and the patella tracking improved. And we were happy to see that by the end of the 12 weeks of rehab, she was back to playing tennis. So, what I want to say is that the gold standard in a patient care is still the basic clinical exam. You cannot skip the basic examination. You need to examine the whole limb, the whole patient as such. And second, sports involves very skillful movements. So a problem in a joint or a muscle, you must always look at the whole kinetic chain. Now we have seen the problems in the hip can present to us with problem in the knee, like in Vaishnavi's case. We have also seen people presenting to us, sports persons presenting to us with back pain, and when we examine, the problems are in the hip, and then they present with the back pain. So it is always imperative that you examine the whole kinetic chain and keep that in mind whenever you're dealing with a sports person. Thank you.